Well, thank you. I'd like to thank the organizers, and it's a pleasure to talk about this topic, which really I've been involved with for about 15 years now. I'd like to put this slide up to just remind you all that TNF antagonists are not new drugs. This is the first report of treatment with infliximab in humans by Sonja van Deventer in The Lancet in 1993. So there's been a lot of water under the bridge, 20 years of development, and we've come a long way. Sonder now is no longer a gastroenterologist, he's a venture capitalist, so that should be a message to you all about the future. So TNF antagonists have been breakthrough drugs, but as this graph, these sets of graphs show, really we're far from perfect. This is not GERD therapy, we don't have response and remission rates of 90%. So we need to do better. And although the TNF antagonists have been really important drugs, they have one big problem, and that's an increased risk of serious infection. And that's not to say that these drugs are unsafe in a patient with few medical problems who's young, but older patients with multiple medical problems, we've all seen problems. These are data from the TREAT study that Gary Lichtenstein headed up, and we see that infliximab is an independent risk factor for serious infection, and along with disease activity, narcotic use, and age. So, and this is really the most common serious infection with TNF antagonists is lobar pneumonia with pneumococcus, and this is the highest mortality problem. So I'm going to talk about the Integrin antagonists, and I'm going to review the molecular biology of these agents, talk about the key efficacy and safety, talk about horizon agents, and then give you a very brief opinion on positioning. So the molecular events that govern the egress of white blood cells from the vasculature into the tissue is complex and dependent upon many protein-protein interactions. And you can think of multiple strategies to prevent that. A very simple concept, if the bad T cells are trapped in the vasculature, they can't get into the tissues and cause tissue destruction. And if you take the time to actually talk to patients about that, it's very important to get the patient on your side and understand this concept, because they actually do understand this. They know that it's better to treat inflammation in the target organ than the systemic immune system. So this is conceptually important. I was glad that Silvio didn't talk about this concept that he really was important in advancing, because if you think about if molecular interactions to get cells into tissues are very complicated, you can imagine that getting them back out through the lymphatics is also complicated and very tightly governed. And I'll talk about one agent in that regard. So this started out with an understanding of the importance of alpha-4 beta-1 and alpha-4 beta-7. The ligand for alpha-4 beta-1 is VCAM, and this is the adhesion molecule that's on every vascular bed in the body. In contrast, alpha-4 beta-7 is restricted to the gut. And the story really began with this molecule, vedolizumab, directed against alpha-4. So vedolizumab would block both alpha-4 beta-1 and alpha-4 beta-7 interactions. And when we were running the clinical trials of this agent, we had to be blinded to the peripheral lymphocyte counts because they go up about 40% immediately after having the drug administered. So it's a very non-specific effect. However, this was really a breakthrough drug for Crohn's disease. And I'm using the word was, as we'll get to in a minute. This is probably the best data we ever had in maintenance of Crohn's disease, steroid-free remission rate delta of 30% from placebo with this agent. And at the time we originally evaluated at the end of phase 3, it also appeared to be very safe with regard to opportunistic infection until this happened. And this was really totally unexpected. The only time we'd seen PML was in very intense chemotherapy or end-stage HIV disease. To see it in this drug, which we thought was very selective, was unusual. We've now come to understand the biology of PML, the infection with the JC virus being permissive, and the steps that are needed before this drug causes the infection in the brain. And suffice it to say that if you don't interfere with T cell trafficking to the brain, you don't see this. And the more modern agents have avoided this problem, and I don't think this is a risk at all for them, and we have good data. So you can imagine the chilling effect that that had on the development of anti-integrin therapy. Fortunately, we persisted with the more selective agent, alpha-4 beta-7 directed, And it was really these studies in the tamarin model that really took this forward. I think you can see these guys over in the park, actually. They've been set free now. But we came to do the Gemini study, which Gemini 1 in ulcerative colitis. You hear the induction results at 6 weeks in UC with a very, in a tough population of patients, about 40% who'd failed a TNF blocker, and very consistent results on all the major induction endpoints. And then in maintenance, again, the trial hit every secondary endpoint in maintenance along with the primary endpoint, the dosing every 8 weeks being highly effective. And we can see that the really important endpoint of corticosteroid-free remission was met with a very high response rate. Now, turning to Crohn's disease, here's where things became interesting. At 6 weeks, this is co-primary endpoints from Gemini 2, and the 100-point decrement response criterion was not met in comparison to placebo. However, the remission rate was statistically different from placebo at 6 weeks. However, the absolute difference was relatively small. And this called into question the efficacy of vedolizumab induction therapy in Crohn's disease. The maintenance data looked like a lot like UC. So if you did respond and were re-randomized into the maintenance phase, we saw a very clear signal that suggested efficacy. Now, to further address the issue, one of the things that I think we saw earlier in Gary's talk was that you're better to start off with patients who are naive to any drug, and that Silvio offered up the explanation that there are immune mechanisms that may govern this. So this, I'm just showing the data, 2 panels, right and left, TNF antagonist naive versus patients on the right-hand side versus the left-hand side, patients who had failed a TNF blocker, and approximately 50% of patients in Gemini 2 had failed a TNF blocker. And this is a very important message clinically. Your best shot, your first shot is your best shot. So a lot of us tend to hide away a drug that we think is very effective, and mathematically, if you lose 10 to 15% each time you fail a given agent, you're better off to start at a high level than a low level. So it's a bit counterintuitive. This is the study that really salvaged the day for induction therapy in Crohn's disease for vedolizumab, and it was conducted by Bruce Sands. And this was the first study that looked at both 6-week data and 10-week data. And the 10-week data in this study were really quite impressive, both for response and remission, indicating a very important optimization message that this is not a 6-week drug. This is a 10-week drug, a 14-week drug, as in the product monograph. So you have to get the patient through the induction phase in order to get the benefit. And now, if you pay attention to one slide, this is probably the most important slide, and I believe that this paper was one of the most important papers published in IBD last year. This is an analysis of the Gemini program and all the randomized controlled trials that were conducted in both UC and CD, looking at placebo-controlled trials and comparing rates of infection, in this case serious infection, any infection, and lower respiratory tract infection. What we see here in the pooled data, UC and CD versus placebo, that the point estimates for the rates of serious infection and respiratory tract infections, pneumonia, were actually lower in the vedolizumab group than placebo. And in the case of any infection, the confidence intervals did not overlap, indicating a statistically significant difference in favor of drug. Well, how can that be? Placebo's nothing, right? Well, remember what I showed you about the treat registry. There are other factors that drive whether you get infected, namely disease activity and corticosteroid use. And if you offset those factors by giving an effective drug, you can actually get a risk offset with regard to infection. So a very important observation, underscoring the safety of vedolizumab as an agent. Now, with the data regarding the rather poor inductive effect in Crohn's disease, we began to look at how to optimize this drug. And well, I mentioned earlier, if you look at ulcerative colitis, these are the patient-reported outcomes. And what we're seeing is that naive patients do much better than patients in the overall population. And these outcomes are the ones that you evaluate in the clinic: rectal bleeding, stool frequency. And you can see here that the naive patients do much better than the overall population. And to address the issue of rapidity of onset, we had the opportunity to look at the change in scores. This is a Crohn's disease study, Gemini 2, and presenting the data as a percentage change over time through 6 weeks. So remission, very small delta, but we actually look at the change in the patient-reported outcomes. And this is the composite endpoint of abdominal pain and stool frequency from baseline. And you see a very dramatic difference. Remember that these patients started at a CDI score of over 330, and it's a long way to fall to 150. But what you're seeing here is very nice separation with both outcomes in this subset analysis. Now, away from the clinical trials, it's amazing how many open-label observational studies we had that were published within a year of the drug coming on the market. And I'm just showing some of the studies from France, Germany, and the US. And very important data in that these studies actually use the labeled endpoint to evaluate the patients, looking at 14 weeks in distinction to 6 weeks. And you can see very acceptable rates of remission in these open-label studies. And amazingly, again, there's been a meta-analysis of the study and recently reported. And when you look at these data, for those of you who are used to looking at pedograms and looking at a risk ratio of 1 as being no difference, that line of identity for these studies is a bit confusing because it's really not that. The line is actually the average estimate in the pooled studies. And what you see is roughly a 60% response rate at 6 weeks and 14 weeks in ulcerative colitis. And then turning to the Crohn's disease, a very similar picture. So quite a different message than the clinical trials actually indicating efficacy in Crohn's disease. And it reflects these patients would have received concomitant medications, they would have received adequate steroids, and you get a different picture than the very refined, purified world of the clinical trial. I'd like now to just switch gears and talk a little bit about pharmacokinetics of vedolizumab. And what you're seeing here are the exposure-response relations from the various populations in the trials that were conducted, the Gemini studies primarily. And you can see that there's a bit of a dose-response curve there. It's not in the SANS trial on the left-hand side at the bottom, not so apparent. But the other studies, it looks like there's a threshold value that is associated with greater efficacy. And that is about 20 micrograms per milliliter. There are now commercial assays available for vedolizumab. If the pharmacodynamic model that we've generated from the trial data would suggest that that is approximately the target level in those assays. I would trust these assays to measure drug. Unfortunately, the anti-drug antibody determinations, it's a very complicated process to validate an antibody cut point because you have to walk it back to clinical data, patient's failure, and impaired pharmacokinetics. And that has not been done with any of the assays that you currently use, except for the Prometheus assay for infliximab. So this is something, future directions we need. Another important point to make is that I believe that there's considerable misconceptions about immunogenicity of vedolizumab. And not surprisingly, because when we reported in the manuscript the rates of immunogenicity, which were approximately 6%, unfortunately, that was with a drug-sensitive assay, meaning that it's not tolerated, the antibody assay is not tolerant to drugs, so you can't measure antibody accurately in the presence of drug. So these are data from the washout period when patients were taken off drug, and we get a very clear picture here that looks very much like infliximab and adalimumab and some of the other antibodies. So the overall immunogenicity rate was 10%. If you look at combination therapy, it drops down to 3% and 12% for monotherapy. Well, what's the clinical importance of this? Because the most common question I get asked is, should I give combination therapy with vedolizumab? I really don't want to, because that's going to take my shiny new gut-selective drug and contaminate it with an old-school, ugly immunosuppressive. So I don't like giving complicated answers to the question, but this one is a little complicated. If you have a patient who is going on biologic therapy for the first time, is moderate risk, and they are opposed to immune suppression, I'm not going to spend 45 minutes talking them out of it, because chances are you're not going to be successful. And remember that the immunogenicity rate is only around 10%, so 9 times out of 10 you're going to get away with it. You still have a TNF blocker in your back pocket, and you're going to have a different conversation if the patient does get unluckily in that 10% group and gets sensitized. So that's quite in contrast to the type of patient many of you are treating with vedolizumab, patient who's failed 2 TNF blockers and really doesn't have a lot of options left. Well, in that case, I'm going to give full dose immunosuppression, notwithstanding that I don't have a sonic trial to show that it's effective. I'm going to generalize the results of that situation. Now, everyone else lives in Middle Earth, okay? They're not on those two extremes. And in that case, I think you'll find that using oral methotrexate at a dose of 12.5 milligrams, we now have 3 studies that indicate that that's the optimal dose, is a very well-tolerated and successful approach to preventing immunogenicity, if that's your only goal of therapy. Now, I'd just like to talk a little bit, maybe reduced immunogenicity can lead to favorable results. I don't really like these types of studies. These are safety studies, open label extensions, that morph into efficacy studies. Clinicians like to see long-term data. Unfortunately, it's very difficult to get controlled data once you get beyond a year. So this is a long-term extension study with ulcerative colitis with vedolizumab, and the message is that this seems to be a durable effect over the period of observation. Now, to finish off and talk about some additional targets, you can block beta-7, and etrolizumab is under clinical investigation now in phase 3. This was the phase 2 result. This is a very interesting result that suggests that if you express high levels of alpha E beta-7 in tissue, that you are more likely to respond to this agent. So this may be our first tissue biomarker. Of course, it needs to be confirmed in the controlled trials. And then finally, you can cut to the chase and block MADCAM, which is the endothelial vascular adhesion molecule, which Sylvia alluded to. This is the results from a phase 2 study. A very interesting dose-response curve, whether this is real or not. Again, this molecule is going into phase 3 development program. What about the relative efficacy of this? Cochrane review, point estimates for vedolizumab at the top, etrolizumab, and anti-MADCAM. And you see they all look for induction, they look roughly the same. So my view is there's probably not going to be huge differences between these agents. And then finally, I just wanted to allude to the yin, to the yang of adhesion molecule therapy, and that's the class of S1P1 agonists. The concept here is lymphocytes need to get out of lymph nodes, and the way they do that is that they have a receptor on their surface which recognize phosphate residues on the lipids lining the endothelium of the lymphatics. And they follow this gradient out of the lymph nodes. We can give a drug which essentially internalizes the receptor so they can't recognize the gradient and they're trapped in the lymph nodes. So with these drugs, in distinction to Tisabri, they drop the lymphocyte count about 40% as opposed to rising it to that level. And the first drug in this class was Vedolizumab. It's widely used for multiple sclerosis. It's an oral agent. It has a number of side effects, primarily due to the fact that it interacts with many of the different isotypes of S1P1. Ozanimod is a cleaned up version which is more specific for the S1P1 type 1 isotype. And we've showed last year in the New England Journal of Medicine that it was effective induction therapy for Ozanimod for ulcerative colitis, and it's moving into phase 3 program now. Positioning here. Look at the various properties. I've shown you induction data in Crohn's disease and ulcerative colitis. Certainly, vedolizumab is a very effective induction agent, very effective maintenance agent. It really shines on safety in UC. In Crohn's disease, it's a slower acting agent, and the rapidity of onset is quite fine in ulcerative colitis. It is slower in ulcerative colitis. It can be a monotherapy, but perhaps not to the extent that ustekinumab is a monotherapy in Crohn's disease. So it's equally immunogenic as the TNF antagonists. And then fistula, we don't really have much data in that regard for either ustekinumab or vedolizumab, and the TNF blockers are per in that situation. Extraintestinal manifestations, theoretically vedolizumab be weak in this regard. We've recently analyzed data from the Gemini programs and we see a benefit. So I'm going to close now with these conclusions. Essentially, maybe I'm not going to close with any conclusion. Okay, so I've talked about the class in general. I've talked about the mechanism of action. In ulcerative colitis, this is a first-line therapy. In Crohn's disease, it would depend on the use of the agent specific to particular patient characteristics. We now have 3 classes of biologic drugs, so we'll be tailoring these to individual patients. The safety profile is really the stellar aspect of vedolizumab therapy. And so it's a first-line agent UC, patients at risk for infection, the elderly, major medical problems, history of malignancy, and contraindications to the TNF antagonists are the primary indications for this drug. Thank you.